Thank you very much to Raphael for having invited me here locally to speak about, in the next 20 minutes, an update on anti-seizure treatment. Now, I would like to show you what, as pediatric neurologist, epileptologist, is a good anti-seizure treatment nowadays. What does it consist of? And that's my structure of the presentation. I would like to give you an introduction and then talk about what is a rational anti-seizure. We don't actually use anti-epileptic anymore. Treatment, what is that? What is precision medicine doing in anti-seizure treatment? Why are comorbidities and directly related deficits important for us to know? And what is pharmacoresistance actually? Drug monitoring, and then conclude. So, as you all know, the prevalence of epilepsy is less than 1%. And there is a certain peak at the beginning of life in the neonates and at the end of life. And in pediatrics, actually, we have a lot of off-label use. Why? Because studies are sparse and approvals limited. We have some studies, but often we actually work off-label. And what is our aim when we treat actually child with epilepsy? Well, we would like to have him protected from seizures. That's why we call anti-seizure treatment nowadays, because we know we protect them from other seizures, but that's actually the only thing we really can prove, because anti-epileptic drug is not used as term anymore because it's not really proven that we have this anti-epileptogenic effect. Yes, for sure. We would like to taper off anti-seizure drugs in neonates, for example, after 1 year. They have an epilepsy and we taper off after 1 year. In the self-limited focal epilepsies of childhood, for example, or the idiopathic childhood epilepsies, we taper off after 2 years, in juvenile 3 years. But do we really have an anti-epileptic efficacy in our drugs, or is this also just due to brain maturation? And another point is we would like to protect the brain from seizures, from the negative effect of seizures. So we know that if we don't treat neonates seizing, well, they have not a good outcome. So sort of we would like to make this neuroprotection. But this is not something we can prove either in human beings. It has been proven in rats, but not so much in human beings. So what is about epilepsy disappearance? For example, due to development, and what's about epilepsy surgery? So the pharmacoresistance is 15 to 20% in childhood. That's actually unchanged, and in adults, 30%. And a rational anti-seizure treatment at pediatric age needs, for us, epileptologists, that we exactly know what is the seizure type the child has, what is the epilepsy type, or what is the epilepsy syndrome, because the treatment we will use is very much depending on that. But also on the cause, the etiology of epilepsy. So is it genetic? It can be structural and genetic at the same time, as you heard, but that's important to know. Then we need to know what are actually the modes of action of our treatments, because otherwise we treat without knowing what we do. And we need to know about interactions and synergisms and adverse effects, dosage dependencies. And that's the way we try nowadays to do really a personalized anti-seizure treatment. And we have a lot of anti-seizure drugs nowadays, more than 40. And the newest ones like perampanel, brivaracetam, or cenobamate, or fenfluramine, which is not really new, but it's new again now, the indication for Dravet syndrome and Lennox-Gastaut syndrome, or we have CBD. Actually, they changed something, but they did not really change the pharmacoresistance part of epilepsy patients. Epilepsy surgery, very important to think about. That's what it's all about today. But we have alternatives which are not what are anti-seizure treatments, but not drugs, like ketogenic diet, like modified Atkins diet. We have the vagal nerve stimulator, and we will also have the deep brain stimulation in children, at least in the future. But the new generation, what they did is actually they improved the tolerability. We have maybe less interactions and a better tolerability, but not the proportion of pharmacoresistance was not really changed. And that's why it's important that we really know what we do by giving an anti-seizure treatment. And we have to know, are we rather on the inhibitory side of the neurotransmitter system or on the excitatory side of the neurotransmitter system? And what are we doing with this drug? And when we give a drug and we have to give another one because the first does not react, then we have to think we should not use the same mode of action, and so on. So have in mind what is your seizure drug really doing. And that's why the most important mode of action are sodium channel blockers, are GABAergic transmission potentiation, is modulation of voltage-gated calcium channels, or a blockage of T-type calcium channels. But we also have, for example, in levetiracetam or brivaracetam, the SV2A mediated modulation of the transmitter release. We have enhancement of potassium currents, AMPA receptor antagonist, as well as in fluoramine agonist of the serotonin receptor. So lots of modes of action. And we have several of these drugs. They don't have just one mode of action. And that's important to keep in mind. What is my drug doing? So if you combine two drugs with the same mode of action, you will actually not really have a better effect. You rather have more side effects. So you should actually add another one with another mode of action, maybe with a synergism if possible. And we have new drugs coming up, or which are already there, which allow to make precision medicine. For example, everolimus, which makes an inhibition of the overreactive and dysregulated mTOR pathways in tuberous sclerosis complex, for example. Or we have cenobamate, fenfluramine, as I said, for Dravet syndrome, Lennox-Gastaut, piperidine, melatonin. We have bumetanide. We have other drugs coming up. And we have, and this is the last, I just mentioned there at the bottom, is the gene therapies. We don't really have gene therapies yet for epilepsies in childhood, but there will come. We have for SMA, but for Dravet syndrome, I think that's the next one coming up in epileptology. And then we really have the possibility to make precision medicine at its best. Now, what is important to know whenever you treat a child? You have to know that we have certain ages, they are completely different. If we treat newborns, we have to know that if they're immature, they can have excitatory instead of inhibitory effect of the GABA A receptors. They have insufficient postsynaptic mechanisms of inhibition. They have a prolonged gastric emptying. They have also lower protein-binded fracture and a stronger diffusion into the tissue. And this is important when you treat a newborn and you give a certain dosage, that you keep in mind this special aspect of the newborn treatment. In infancy, we have a faster absorption, variations, clearance, which is higher, and the intestinal transport is reduced, the absorbing surface smaller. And if we go into neonatal age, as I said, why is it excitatory instead of inhibitory if we give a drug reacting on the GABA? Well, because the intracellular chloride concentration is the key point. And if the intracellular chloride is actually high, and this is the case for immature neurons, then GABA is rather excitatory than inhibitory. And this depends all on the chloride co-transporters, and they depend on the maturity of the neuron. And the neuron can be not the same mature in the cortical area, but maybe in the subcortical area. And this makes the treatment difficult. And phenobarbital, for example, can then, in a preterm baby, have the opposite effect. And we would like to actually have an inhibition, but it can be excitatory instead. So precision medicine means we have a child with seizures and an epilepsy, and we try to choose the good drug, which is seizure type specific. And already at that point, I mean, he might not be pharmacoresistant at that point, but we already ask ourselves, it's a focal seizure. Is it maybe a structural one, like on the right side about the etiologies? Is maybe a surgical evaluation a possibility? Then we go the next level. If whenever we have an epilepsy syndrome, maybe there is a drug or a drug combination which works well, And we try to be epilepsy syndrome specific. And also there, we have to ask again, well, it doesn't work well. Is actually the diagnosis correct? And do we maybe think about the etiology? And is there epilepsy surgery a possibility? And 3 level would be the gene specific. And we have now a list of epilepsies. They are actually where we have a gene specific treatment. It's not a gene therapy, but I will show you what I mean. And also there, what's about epilepsy surgery? So try to ask again, do I have the correct diagnosis? If it doesn't work well, the anti-seizure treatment, I have to think about maybe the diagnosis is not correct. Maybe I have to choose another approach. And not forget the comorbidities, but I will talk about this. Now, precision medicine is complicated, as you see, because we have so many genetic variants. And of all these genetic variants, do we have specific treatments? No, we don't. But part of them we have. But as epileptologists, you should have as best an overview of this and know what you do. For Dravet, for example, Dravet syndrome, we have a quite syndrome-specific treatment nowadays. And Eliane Wirrell, she wrote this in an epilepsy statement paper. Well, first would be valproic acid, and then you see step number 2, step number 3, step number 4, and others. And that makes it also precise and individualized. And this is what we want. We just don't want to make trial and error. We'd like to be structured in our procedure when we treat the child. And this is the list which exists nowadays in gene-specific treatments in childhood. So we have self-limited neonatal epilepsy forms, or we have encephalopathies, or we have a whole bunch of metabolic epilepsies with treatments, with gene-specific treatments. And we have to know them and apply them so we can treat the child a lot better. And that will be a very good, I would say, level of precision medicine nowadays. Unfortunately, we don't have that for all of them, but for a part of it exists. Now, the comorbidities. If we talk about comorbidities, that's actually something, an entity which comes up together with an epilepsy, but it's a disease on itself. And you have to differentiate between a comorbidity and a directly related deficit due to epilepsy or anti-seizure drug. And to disentangle these is not so easy if a child has 2 anti-seizure drugs and still has seizures. So what is actually just a comorbidity and was it directly related? And it's a complex system because sleep also is a very important aspect for regeneration of the brain and learning. And when sleep is fragmented due to seizures, well, then it's going to lower the threshold and then seizures are even increasing. If you have a comorbidity like obstructive sleep apnea and you don't treat obstructive sleep apnea, your epilepsy might worsen. So it's important to know all these aspects and treat them as well to have a best treatment possible also for the epileptic patient. Not only anti-seizure treatment, but also all comorbidities and directly related deficits. And here is a nice paper about all possible comorbidities on cognition, directly related deficits concerning cognitions, but also comorbidities in different types of epilepsies. Now, pharmacoresistance, as I said, 15% have pharmacoresistance, 15 to 20% in childhood. EEG can be a biomarker for pharmacoresistance. We have some hints what could mention actually pharmacoresistance, but how predictable is pharmacoresistance? Well, we know that the first anti-seizure drug should be chosen well because it's actually the one having the best effect of controlling the epilepsy, then the second, then the third, and this is actually decreasing. But to predict is difficult. But we should know what actually means pharmacoresistance. And we have different hypotheses. We have the transporter hypothesis, which is the increased PGP, which is in the endothelium. It's actually protein, which is there to transport. So it makes an efflux actually of the anti-seizure drug from the cell outside. And if there is more efflux, and this is the case in pharmacoresistance, you will not have the anti-seizure drug in the cell and it's not going to react. So more is going to be out of the cell. And this is one possible hypothesis where even selective PSG blockers can be applied, eventually decreasing pharmacoresistance and increasing the level in the cell. Then we have the target hypothesis, which target site alterations at molecular level with alterations of the receptor subunit expression through pharmacoresistance. And this is also important to know. And intrinsic severity model, which is just a lot of seizures, a lot of high frequent seizures with more resistance coming up. There is another one, and this is, I think, important for all of them. If they have a high seizure burden, or if they have a very high frequency of epileptic potentials, continuous epileptic potentials in EEG, well, we know that this is going to induce also axonal sprouting and maybe structural alterations, neurodegeneration, neurogenesis, gliosis, and this makes an abnormal neural network. We can even learn to become epileptic, and normal tissue can learn to become epileptic if the epilepsy is very active. Then we have the genetic hypothesis, but we don't have yet a genetic model existing. And we have the entire inflammatory aspect. We know blood barrier dysfunction, neuroinflammation, which sustain epileptic activity. We have microglia and astrocyte dysfunction and so on. And this is also a hallmark for the epileptic zone, and also responsible on one hand, part of it for the epileptogenesis and epilepsy progression, as well as pharmacoresistance. So how to monitor? When we have an epilepsy, how can we monitor? Well, we would like to have drug levels showing us, do we really have a good level in the blood? But actually we should know what is really working, and not what we find in the blood, but what is really reacting in the cell. And this is also difficulty, and that's not what normally we see when we do blood levels. So drug levels are useful to check the compliance, to see if they're an incomplete response. It's important when you make a polytherapy. Also when we see, well, what is the efficacy and maybe side effect to weight up. But we need objective levels, and we need good tolerability biomarkers, and we need actually to understand, is this a responder or not responder, by looking at biomarkers. And this is something which now comes up. And one biomarker could be, for example, Pablo Sinuez and his group, and I'm also part, he developed a new technique how to measure actually the drug levels in the air by pathway-driven breath metabolomics, which is easy to do. Well, it's a complicated machine, but it's easy to do. And it can even show what is the active component of the drug, and also show you, is there a good balance or not a good balance? So maybe also even predict pharmacoresistance. We also have to use the good devices, like, for example, to objective how many seizures a patient has by using the night watch, because as you know, a patient cannot always really predict well how many seizures he has. Maybe this is better in infancy and in childhood, but still we have there a problem. You have to be clear when you have a diary, what happens there, and so on. And we have to think that there is also even a circadian part of the seizures coming up. So we need to know all these aspects to have the patient optimally treated and to have a personalized anti-seizure treatment, not only with drugs. So to conclude, if we do a rational anti-seizure treatment, then we should be child-specific in what we do. We should see seizure-specific if possible. Syndrome-specific would even be better, and gene-specific is what we want. And I think we will achieve this, but with the time coming. A rational anti-seizure treatment is not always possible, and comorbidities as well as directly related deficits, they have their impact on cognition, and it's important to know them and to treat them, to do the correct thing, because you can also improve the epilepsy. Do we know what happens in pharmacoresistance? Yes, there are a lot of hypotheses about what is pharmacoresistance, and we should actually avoid pharmacoresistance. So if we can treat a child by giving him epilepsy surgery, well, then we can actually make disappear this epilepsy and come out of this pharmacoresistance. And this is actually the most important thing. Should not remain into pharmacoresistance if we have other options. And time is brain, or time can be brain, because we should not wait. The longer we wait, the worse it is. In the case of pharmacoresistance, surgery is not always possible, but it can. If it's not possible, actually, then we need to find a good balance. How many anti-seizure drugs do we give? Do we give 4 anti-seizure drugs and the child is only sleeping? That's not a good option. So we also have to find a good way in between if there is no other way to treat it. And we have new monitoring techniques which can help to optimize and to improve treatment and to have this treatment as personalized and as precise as possible for children. Thank you very much.
Thank you very much, Alexandre, for this very important topic about the therapy in pediatric epilepsy. There are questions from the audience.
I have a question. I think it came from the new pediatricians that they made the statement that you need only one drug to show it failed, and then you proceed to surgery. What happened to that?
Well, I think the definition didn't change. It's still 2, but the question is, do we really need the definition of pharmacoresistance to go to a pre-surgical evaluation? And that's what I think is actually absolutely possible. You may have one drug used, but you're sure it's a lesion and you're sure this is going to be pharmacoresistant. So why to wait for the second to fail? I think we have to be open and evaluate such a child also without pharmacoresistance if we are sure that this is the right direction the child is going, because we know that the time is not in favor of cognition if you have an active epilepsy.
I think there's a new recommendation from the IME, exactly how you stated it. It's a lesion and one drug, and that's enough, at least for adults.
Yeah.
But I wasn't sure about children, which should be even more like that.
May I make a comment?
Yes.
There is a new guideline, came out over a year ago, and in the new guideline, we are supposed to refer patients for epilepsy surgery, regardless of age, even if they're seizure-free on 1 or 2 drugs, but have an operable lesion far away from the elephant cortex.
Yes,
yeah.
So exactly. That's what I was referring to.
Guideline for timing of evaluation.
So we don't need to talk of pharmacoresistance anymore as a basis to evaluate the child. Yeah, absolutely.
I mean, if it's somebody seizure-free, maybe that's an individual decision if the patient wants to proceed. But I refer to the same guidelines because it has changed. And I think it's a dramatic improvement in favor of epilepsy surgery. Usually the first drug works a few years and then it comes back, and then you have to do another drugs and another use, and then all of a sudden you lost, I don't know, 10 years or so. And then
I actually will show a patient afterwards, and she had 3 anti-seizure drugs. She was 1 year and a half, and they didn't. The first 2 they could not actually control the seizures. All of a sudden she had 1. And now she's seizure-free, but she has cleared a dysplasia. And we know it's a matter of time that this dysplasia is going to be active again. And we have to discuss epilepsy nevertheless, because we know by waiting it's not going to be better. The child is not going to improve. Yes. Patricia.
So in terms of the terminology, you say there is probably no anti-epileptic medication, but I think with those like mTOR inhibition on TSC, and also sometimes reversing even the cortical changes, I would say you have anti-epileptic medication, but it's really based on the pathophysiology, and so I think in future we will have more of these terms and of options for the genetic.
Absolutely, but I think the term was changed because we just realized that it's most of the time it's anti-seizure
symptomatic
treatment and not anti-epileptic. But I absolutely agree that this is something which is going to be more and more the case. Yes.
We have time for one question.
No, thank you for an excellent talk, Alex. In the pharmacoresistance, you also talked about the neural network hypothesis. And it goes along a little bit with, how early should we react to the next step? So is there a correlation between waiting and being pharmacoresistant or being suboptimally treated and the formation of those neural networks that actually learn the brain to be epileptogenic? Is there such a correlation?
Yeah, we know this correlation actually is already the case in neonates if we don't treat them correctly, and they have also just electrographic seizures, and we just don't treat them because we don't maybe look at them, because we don't do any video, and we know that they have a worse outcome. So there is something happening on the neuronal level already at that time. If we have a pharmacoresistant, and we know this is a child who could be operated, well, then it does make sense to wait, because this is the process which is ongoing, and it's in disfavor of his outcome from the cognitive side, for sure, yes.